Hey class, here we are again with another recording. This lecture is basically from chapters 8 and 10, and it's stuff that it's going to be self-evident that you've seen in our lab and that you've seen in the x-ray rooms. So this is basic x-ray equipment uh, and x-ray tube head that you've seen in lab already. We will go over some of the parts. This would be an X-ray tube, what it would actually look like inside of the X-ray machine. If you could take off all that tube housing, this is what it would look like with a rotating anode and a cathode here, and this is the different parts. If we look at it in a schematic, you can see this is the anode, which rotates, it turns around. I'm not going to ask you all these things because you'll have it later on in equipment, and also you'll have it the equipment an equipment class and you'll have an exposure class. But the things we'll look at, the two things I want you to remember, this is the anode, it rotates, it spins around rapidly. This motor here is what makes it rotate. And this is the anode end. It is the positive end, A plus. This is the cathode end, C minus. So you would rather have an A plus than a C minus, I'm sure. It is housed in a glass tube here that is evacuated, so it's a vacuum. This is called a filament, and it is where the X-rays electrons are it's a current. Think of the filament in a light bulb. This heats up, and the electrons come off of this, but that's deeper than we want to talk. Hits the rotating anode, and X-rays are produced. What I want you to see is that it's an anode, a cathode, and that there's a little window that lets the X-rays come out. This is all enclosed in a tube housing that is basically a lead housing that doesn't let the images, the X-rays escape, except it does. So again, what I just said here. Electron is the cathode. Electrons are on the cathode end. The X-rays are produced on the anode end, and this is again showing you this that the C plus and the A plus and the C minus here. And Mr. Dawes was so kind to make us a little thing. Don't panic. Positive is anode, negative is cathode. You want an A plus, not a C minus. The basic things that we're going to talk about, the types of x-rays. The primary beam is what we're producing in the x-ray tube that leaves the x-ray tube. As you can see, it spreads out, it diverges. So this is the primary beam that leaves. The transmitted radiation or the transmitted beam is that part of the x-rays that actually go through the patient and hit our image receptor. There's also scattered radiation. This is the radiation that hits the patient. Some of it's absorbed by the patient internally, some of it bounces off. So it is scattered, just like throwing things around a room. It is not useful to us. It exposes us as technologists, and it also degrades the image because it is not part of the primary beam. So primary radiation is what leaves the tube, transmitted is what goes through the patient, and scattered is what is not useful for us. There's also something called leakage radiation. That is the tiny bit of radiation that actually escapes from the tube housing and goes in different directions. It's not really scattered. We just call that leakage radiation. It usually does not get even to the patient. Again, we said scattered radiation is bad because it is what exposes us if we're in the room or anybody else that's in the room, and it also degrades the film. So it's bad for us and it's bad for our image also. Much of the radiation that's scattered is internal scattered for the patient, and that means that the patient is getting exposure, but it's not getting he's not getting any benefit from that. The person is not getting any benefit from that because it's just radiation that is scattered and absorbed by the body. Leakage radiation is that part that leaks out of the tube that we just said. There's only a small amount of this because it's in a lead housing, but there is a little bit that leaks out. If we look at the X-ray table, again, it should be freely moving. Most tables that you're able to lower the height and raise the height, that was not always true. They need to be something that is easy to clean, that you can clean thoroughly, and they're going to have a Bucky assembly, and you can see here. Again, we will look at a little bit more of these pieces. The Bucky is where if you were using the film, because these are made where you could actually use a film. Most of them, if they have a Bucky like this, you could use the film, you could use a CR plate, or you can use a DR plate. It's where you're going to place the image receptor. We usually use the Bucky if the body part is more than 4 inches or about 10 centimeters, or if we're using a KVP higher than 60, probably now that would be higher than 70 with some of the modern equipment. We get better pictures when we're using this Bucky because there's a grid built in here. The grid is what absorbs that scattered radiation that we don't like. Uh, to get rid of something called grid lines, the Bucky actually, the grid actually moves, vibrates back and forth. That's called a reciprocating grid. The upright Bucky is just like the table Bucky, except it is turned in that upright position. Here, it's standing up instead of lying down. The patient stands up, but all the components are the same. If we talk about the grid, this is an independent grid. And if you look in the lab, we have grids. If you're doing, when you were practicing on doing the decubitus images, you used a grid that you applied in front of the image receptor. And we would apply this in front of the CR, the DR plate, either one. Um, and so it picks up the scattered radiation that degrades or makes our image poor. If you're using it inside the Bucky, the grid is built in. You can't see it, but it's built in. And anytime you use the Bucky, there's a grid being applied there. So you use the grid, and it again picks up the scatter. You only use the Bucky if you're doing a thicker body part. So what are grids? Like I just said, they're things that pick up the scattered radiation. So if this is the X-ray, the object, the scattered radiation. So the best images that we get is the radiation that comes straight down in the center of the X-ray tube. We'll talk about that in a second. But there's a grid here, has some lead lines in it, and the X-rays that are deflected and go sideways, they get blocked by these lead lines, and so it picks up the scattered radiation. So grids help improve images by getting rid of scatter. That's what I want you to know. If you look at these two images, this is an image of exaggerated certainly, but without a grid, you can see how it's a little bit fuzzy, and here with the grid, the image is very plain. And you'll be able to see that in images, especially thicker body parts, if you forget to use the grid. Um, Types of supporting systems, we basically have three types. Ceiling support systems, which is what we have in our lab, but we used to have in the old lab floor support systems, and then we have the C-arm or the U-arm that's self-contained. This would be the example of a C-arm or a U-arm. If you look in, we have one of those in the back, kind of the storage room where we keep everything else. It is mounted, so it can be like a C or a U. These two things are always facing each other. Now you can turn this upright, you can angle this, but these two things are always going to be facing each other. The Bucky will stay aligned with the X-ray tube at all times. The ceiling mount is what we have in our lab. It's mounted to the ceiling. It's very versatile. You can move this over, shoot from this side. You could shoot from this side, like when you're doing a cube. You can turn it and point it toward the wall Bucky. And sometimes the wall Bucky and the table Bucky are not aligned. If you will look in some of our rooms, the wall Bucky is more to the side, so you have to transversely center differently. And so this is very versatile, lets us do many things. The floor support system, we had this in our old labs before we had our new ones. It's cheaper to install because this is mounted to the floor, and so the X-ray tube can move up. It can move vertically and it can move transversely. Well, it can move all three directions, but you can't use it as much. You can't go on the other side of the table, and the wall and the table Bucky have to be lined up. So you see this more in clinics or in small offices. If we're talking about the image receptors, we could have three things: a film cassette, which is a cassette that holds the X-ray film, which we don't routinely use anymore. We could have a CR imaging plate and a DR imaging detector. So we used a cassette when we had film. When we used a CR, which was called an imaging plate, and we had to use a processor for that. And the DR is a direct imaging and detector imaging or direct imaging, and it automatically sends the image to the screen. So if we look at if this example of them, this is the old screens, the old X-ray cassettes that had an intensifying screen and a film inside of it. This is the CR setup. We actually have a CR reader in the lab. If you look around, you can find it. It's where we put the plates in here, and then the image appeared on the screen. And this is the DR plate, which like we use when we make an exposure. You do not have to do anything. It automatically sends the information to whatever receiver you have, usually a computer, but it could also send it directly to a portable X-ray machine, some viewing screen that is connected to it, and the connection is usually Wi-Fi. So if we just look at these old film cassettes, and I'm not going to spend much time on these, but I was intimately familiar with these because this is all we had. The cassettes raised up, you loaded a film in there. This had to be done in the dark room, and you can see this little black thing here. You put it in a special machine that had all the information about that patient, their name, their date of birth, all those things that we would see on a screen. You did that in the dark room. It exposed it and put the name on there, so each film had its own information on there. The CR plate, you might still see these at some places. I don't know if any of our clinical sites are still using them. They look much like a cassette. They actually have a plate inside of here, and when you put it in this processor, it opens it, it pulls the plate out. It does this automatically, processes it, and then you see it on this screen here. It wipes the information off the screen, reloads it into the holder, and you're ready to make another exposure. So it acts like a film because you can only make one exposure on this without moving it out from under the patient and then processing it and putting it back. The only thing is it's digital now, and it's not on a film. And this is what we modernly use now, the DR plate. It is usually, you can have it be wired, or you can have it be a Bluetooth or direct, or what I want to say, connected electronically, so that you don't have to move the plate at all. And some of these plates and some of the machines, they're permanent in there. A lot of the newer machines will have a DR plate that's permanent inside, and then you will have a mobile one that you can move around to, like do a stretcher or on the floor or tabletop, wherever you want to use it. The thing about it is, this is just the charger. This is not the processor. This is just charging the plate. Again, you can see this in our lab. And then it sends the information to some screen. The things with this, it's very expensive, as much as a nice car. So you don't want to drop them. Fluoroscopic room, we don't have a fluoroscopic unit. Those programs do not, but you'll see these in the hospital. Think of just the general x-ray as doing a photo, and this is doing a video or a movie. In this case, you have a table here, and you have your general x-ray tube is going to be usually an R and F room, radiographic and fluoroscopic room. So you have the ability to do radiographs in this table, or to do a fluoroscopy. In the fluoroscopy, the table does not go up and down. You can't raise or lower the height, but you can tilt it either up or down. In this case, it's in reverse Trendelenburg if you want to stand the patient up, or you can put the patient's head down. The thing about this is the x-ray tube here is underneath the table, and the receptor is above the table. And we'll talk about some of these barriers here as we get radiation protection. Um, Again, there's going to be many different models and different setups, but basically they're going to all do the same thing. There's a lead curtain here that protects from the scattered radiation. There's a barrier here, a shield here, and then we would wear a lead shield ourselves, and with the monitors on here. Uh, this usually, the technologist is not the one who makes the exposure. There has to be a radiologist or a radiology assistant that makes the exposures here. We're just there to assist, and then we can do any overhead or static X-rays that's required. There's scoliosis machines that will do a complete spine from the cervical spine all the way down to the hips, and they stitch them together. So on the image you have a long image that shows the entire spine. I've never actually seen this EOS machine, so that's new to me. I've never seen that in operation. We use these in several of our X-ray sites, and we will talk about how you do those. But you do standing, AP, and lateral, and it will do the entire spine. And so it's a special setup for doing scoliosis views. If you talk of AEC versus manual technique, AEC means automatic exposure control. Basically what that does is we choose the photocell, and then based on the size of that patient, it determines how much radiation enters the patient, the mass, the amount of radiation that enters the patient. The system automatically stops when a preset amount of radiation has reached the detector based on that body part. And so if you're a thick patient, it takes more radiation. If you're a thin patient, it takes less. Manual technique is when we set all of these factors on our own, and we can make a mistake because if we don't know our techniques, but we would have a technique chart to help us do that. There's two things that we would talk about, the KVP and the mass. And again, I'm just going to hit these lightly because there's a whole another class that Mr. Daza, I think, teaches next semester called exposure or techniques or principles of radiation exposure. The KVP is the kilovoltage peak or potential, the KVP, that's a capital V. Think of it as the power or the penetration, how strong the beam is. So the kilovoltage peak is the penetration power. The MAS is the milliamperage seconds. The MA for milliamperage and the S for seconds. It is the amount, the quantity. This is the quality of the X-ray. This is the quantity of the X-ray. Again, I've just said this is the penetration power of the X-ray beam. We have to have a minimum penetration to get through certain body parts. Obviously, if it's a thicker part or a more dense part, it is much easier to penetrate air than it is bone. So that may make a difference on our KVP. If we don't have an adequate, if we have an inadequate KVP or a KVP that is too low, more of the X-rays are absorbed by the patient than they should be. The milliamperage per second, or the MAS, it's a combination of MA times the time, which is the MAS, is a product of the MA and the seconds, or usually it's milliseconds or fractions of a second, but sometimes it's going to be milliseconds. You can actually break these down and you can set the MA and you can set the time, and then you would multiply those time each other to give you the mass. Most of the time we know a mass we want to use, and we usually change the MA station and it automatically changes the time to get that amount of radiation. But if you just choose 70 MAS, you don't really know what MA station you're using or what time you're using, but the machine is going to default to the least time to get this exposure that it can. MAS gives us the amount of X-rays, so it's the quantity of X-rays. Again, there'll be a whole section on talking about this later. The AEC is the automatic exposure AEC sensors. This would be a sensor, a sensor, a sensor. And if we're doing a chest X-ray, a PHS, we might have these two because we're not interested in making it penetrate the spine so much, the air. But we'll talk more about these again when we have that class next semester. But these are the sensors that we're talking about for the automatic exposure control. Having the correct one set gives us the correct exposure. On the control panel, this is a picture of our control panel here at the school, and so is what it looks like. These control panels will look different at different clinical sites, but they're all going to have the same basic things where you can program the KVP, the MA, and the time. And usually on most of the newer systems, there's going to be something called the automatically programmed radiography or automatically programmed technique. If you also can see that on our machines, you select a body part and it already gives you uh, uh, a, a recommendation on what that exposure could be. You can change that at any time though, and it has to be preset. If it has not been set up, then it will not give you a recommended, but it gives you a recommended exposure for different size body parts, and it usually has baby, child, small adult, medium adult, or large adult. So you might see any of those on there to select. You select the piece of anatomy that's pre-programmed. It will appear of the average size of the patient that you select, but you can select a different patient size. No matter what this value shows, as a technologist, we can alter this value that appears because there are circumstances where we need to use less exposure or more exposure. These can always be changed. They're merely recommendations. Um, you have talked about this just a little bit in your positioning class, but I just wanted to say a little bit about it here. This is not part of the equipment, but it's part of how we use the equipment. So image distortion, that means making the image not appear as it really is. Um, if you think about your shadow, when the sun is directly above you, it's shining directly down on you. Is the sun's coming up in the morning or going down in the afternoon? we have shadows, and those shadows get shorter or longer based on how the sun is angled toward us. The same thing is true of here. The radiation source is coming down here. The best beam that gives us less distortion is what comes straight out of the X-ray tube. As it goes more to the edge here, it distorts because this is the object, but yet the object is being stretched out here on this image here. So the object is appearing larger than it really is. So misrepresentation of the object size or shape because of image distortion. And that happens because the beam diverges or we have the beam angled. So how can we control some of this distortion? Well, if we have a greater SID, that's the source, which is the X-ray tube, and the interceptor is our plate. So the SID, the source interceptor distance, we use 72 inches for that chest. Actually, studies have shown that probably we should use a greater distance for all parts. I went to a meeting where they talked about possibly that we didn't know if the machine was made first and then they made the distance fit it, or if we chose a distance and then made the machines to fit them. So what came first, the chicken or the egg? But really, some of the more modern things are using a greater distance because it reduces that distortion. So controlling factors: SID, source interceptor distance. Increase SID, what I want you to remember is increase SID reduces distortion. And you can look at that here because here the actual object is more like the image you see. Here the object is bigger, the smaller than the image you see because it has a shorter SID. And the other factor is the OID. That's the object interceptor distance. So the closer you have the object to the interceptor, the less distortion and magnification. You can see this is the actual object size if you follow this down, and yet has been distorted to stretched out here if you have the object further away from the interceptor. Here it's closer to the interceptor and the distortion is much less. This dotted line and this other line is much more the same. So decrease the OID reduces distortion. Increase the SID also reduces distortion. How does distortion look on an actual image? Well, if we have a finger here that is parallel, this finger is parallel with the image receptor. Here, it is not parallel with the image receptor. So the joint space is looking like this. This is where your hand and you're not parallel. You got the fingers bent. Here, the fingers are straight out. So each finger, while it's got some OID, it is still parallel to the receptor. And how does it look on a film? Well, here you have distortion because the joint is closed because these fingers are not parallel to the image receptor. Here, where the fingers are parallel, you can see the joint space is open, and that's what the doctors want to see. Same thing if you look at the knee. You should be centered down here for the knee, but someone's centered up here. And so that divergent beam, this would be the best part of the x-ray, but that's not the knee. The knee's down here. So you get that divergent beam, and it's going to do this, and it's going to close up the joint space. Here, when you have it positioned correctly and you want to see that joint open, the central beam is coming down here, and you see the joint open. So that's why it's important to center over the part that you're actually looking at. That's why we get real specific on being, especially on the extremities, where you center actually over the joint, because if you're not really centered over the joint, then you're going to get image distortion. Another piece of equipment is the C-arm. You will see this in surgery and you will see it in fluoro. That's where it's going to be used. It consists of a C-arm. This is the C-arm. And then there's going to be a workstation here where that you can put in all your information and see the image. And I think that this is the workstation where you put in all the information, patient's name, all the things about that, and you can pull up information about the patient, and this is where you see your image. The C-arm itself is, again, the C-arm, usually when it's in this position, when it's in this regular position, the X-ray tube is on the bottom, the receptor is on the top, much like you're going to have in a fluoroscopic unit. The O-arm is an extension. It is something very much like the C-arm, but it is O-shaped or a complete circle. It is like a C-arm, but the images you receive look much like a CT image or an MRI image. They're cross-sectional. They're sectional images. So this could be somewhat considered a portable CT machine. there are portable CT machines. The portable X-ray machine, I won't say much about that. It's one that you can move. It's sometimes called a mobile unit or a portable unit. We use these when we need to take images in a patient's room or not where we have a machine set up. Most of the modern ones now that they're DR, they use the DR plate, and you'll see the image here on the machine. PACS is the Picture Archival and Communication System. Basically, think of PACS is where that we're going to store the images. It is, instead of having a film storage room, we're going to store them on PACS. You can do things for them there. You can alter them. You can look at them. You can send them remotely. They let you do many things. But basically, this is where they're stored and they're shared. If you're in the same PACS system with me, then if I did the Memorial Hermann system, for example, if I had an X-ray at Memorial Hermann Southeast, I could see that if I was at Memorial Hermann Medical Center, if I had the patient's correct information, because all of that system uses the same PACS. I cannot see something in another system unless they send it to me and I download it to my PACS. Again, I'm going to go through this pretty quickly. These are some commonly found items in or around the X-ray rooms, and most of these you've seen. If you go to we don't have oxygen in our X-ray unit, but if you went up to the respiratory unit, they do have oxygen. But in X-ray rooms at the hospital, they're going to have a wall-mounted oxygen, and then you will see portable oxygen bottles that if you're transporting a patient from one place to another, that you hook them up to the portable oxygen bottle. IV poles, oh my gosh, they're just what they're said. They for intravenous fluids or sometimes for blood, however you're delivering, you're wanting something you're delivering to the patient. It can literally hang here and not have all these things and go directly in the patient. Most of the modern ones here go through a machine that you can program to give at a certain amount at a certain period of time. The thing I want you to do is be mindful of these IV lines when moving a patient. You want to be careful that you do not disconnect the IV from the patient. Urinary catheter bags also, you will see these in the rooms, but if you're bringing a patient down to radiography, they're going to hook them onto the stretcher or the wheelchair. Again, you want to be sure that they don't get caught in any of the mechanisms, and you want to be sure that the bag is always lower than the bladder so that it freely drains. You also might see an emesis basin. I would say that you need to know where these are located because when all of a sudden a person has to vomit, these are emesis bags, which you see more often now because they don't spill. When I was in X-ray school, there was no emesis bags. They were these basins and these or vomit basins we called them. And then if you weren't careful, you could spill them here. You can kind of close this off. It's more in a funnel, so it's much better. But these are just receptacles that you're going to use for patient vomiting. A compression paddle, we have one of these in the lab to demonstrate. What this is, this is a radio opaque, a radiolucent. X-rays will go through this. This is just a plastic, like a balloon here. You blow it up with this little inflator here. This is used in fluoroscopy mostly. As you can see, this is an old picture, but you can see the patient lying on this. So it does not block the X-rays. It has a little ring that you can see it, but that lets the X-rays go through. It keeps your hand out of a fluoroscopic beam. If you need to put pressure on a body part to spread something out internally or to put pressure, then you can use this compression paddle, sometimes called a banjo, hence because it's somewhat banjo shaped. Positioning sponges are just what they said, and we've already used those. Sandbags, oh, you may not have used those yet when we talk about doing certain exams. One for sure is the acromioclavicular joint, the AC joint here where the clavicle and the acromion come together. If you have some shoulder injuries, sometimes they will want to see them with weights and without weights. We use the sandbags, and they're literally full of sand that we can use to make the arms relax down and show if there's a separation in that. We use these for a couple of exams, but mostly for AC. You also can use a sandbag to help you hold a patient in position. If you have a child, you can put a foam wedge here and then put a sandbag beside it that will help keep the child from moving. Or you can literally, if a patient has trouble holding their arm or leg still, you can use a sandbag for immobilization. Code button, well, we hope you don't have to use this, but this is if there's an emergency and a real emergency. It's like it's calling the 911 inside the hospital. It activates a system and then it lets people know where you are and they send the code team there. And this usually is if someone's in respiratory or cardiac arrest. Step stools are just what they say they are. Sitting stools is just what they say they are. What you might not be familiar with, and we don't have in our lab, are these devices if you're doing weight bearing x-rays. So you would have the patient stand on here and then you would move that bucket. Think of that wall bucket that you've used. You can move it up and down. So you could have the patient standing here and you do a standing x-ray or weight bearing. It might look like this, it might look like this. What you're going to use it for, it's usually seen in orthopedic offices. For you guys that are going to go to one of the orthopedic clinics, you will see these and use these quite often. If you go to Herman, we're probably not going to see these very often at all. This is also when you're doing a standing x-ray, you put the image receptor here because you don't want to stand directly on it. This is a plate, a shield that you can put over the cassette that you can stand on. It is made so that you're not going to damage the plate under it. So you place them so that the patient doesn't step directly on the imaging detector. And you will see those at the outpatient clinics also for orthopedics. There's a footboard. This is the fluoroscopic unit. This is a board that you can attach to the end of the table, and it lets you stand the person up when you need to do standing x-rays for certain things for the GI system or for a myelogram. And it's just a footboard on the table. You can remove it. This is a lock system. You can move it. You will need to learn how to put these on. It is called the footboard. Uh, then there's also something called the shoulder rest or the shoulder boards. Your head is here and it lets your shoulders rest against here. You would use this when the patient was in the Trendelenburg when you tilted this end down so that they didn't slide off the table. So this is when they're standing up. This is when you put it in Trendelenburg where the head is lower than the feet. Wheelchairs, self-explanatory. A stretcher, well, it's something sometimes called a gurney. You may hear that term more often. We use these for patients. It's easy to transport a patient, especially if they have trouble standing or if they're have a lot of equipment that goes with them. We put them on a stretcher. You will see gurneys or stretchers in the emergency department at Herman that you can actually put the image detector under here. They're specially made for trauma stretchers. Uh, General stretchers are not. We'd have to put the image receptor in front of the pad. On the others, you can go under here, but it's a specially made one. A bed is just what it says. And the thing about the beds and the stretchers, they all have controls on them. They may have electronic things that lift them or put them in different positions. And also, they're going to have bed rails that you have to raise and lower. And sometimes they bring a patient down in the bed, not on a gurney, especially if it's a really critical patient. Sliding board, oh my gosh. I don't know why it took us so long to invent these. There are hard plastic board with hand grips, and you roll a patient and you slide this under, and then you can easily slide even a large patient. You can take the whole board or slide the patient across the board to move them from one table to the other. You would see that the emergency personnel use these also. This is a good example of where you have the sliding board. They're doing a log roll on this patient. I think you guys may have practiced that with Miss Lobren. You log roll the patient, you put him on here, and then you can slide the whole board or just slide the sheet and have him on this board here, on the table here. Lead shields. This is really a little controversial now. We're going to wear lead shields as personnel when we're in the room where x-rays are being taken. If you guys are not going to hold a patient because students can't. But as technologists, there are times when we have to hold a patient. You're going to see this really often in the trauma center. You should have a lead apron on to protect you from the scattered radiation. So typically the type of aprons you will see the technologists wear is a full apron or a top and a bottom. We sometimes use this for patient and families, but we most of the time this is what we will wear in fluoroscopy. We're always going to wear these, or if you have someone that's with the patient that can't leave the room, has to be with the patient, you should give them a lead apron to protect them. This is a thyroid shield that we would use to protect our thyroid because the thyroid is here in our neck. It's very surface and it's radiosensitive. So you may see these used. And most often you're going to see these used in fluoroscopy. Not on the patient so much, but it's on the on our personnel that we're using. lead shield that we would use on the patient. The reason I said this is a little controversial. Some of the newest recommendations are that we don't shield a patient anymore, even though that's going to go against what we teach. We're still teaching shielding, but if we have a collimated beam and the part is not in the direct beam, that primary beam, then most of the scatter or the radiation scatter that the patient is going to receive is internal after it goes in the patient and scatters, and these shields do not block that. But if we're using a shield, you're going to put the shield between the body part and the x-ray tube here. So if you're doing a PA chest, it goes on their back side. If you're doing an AP chest, it goes on their front side. If you're doing a lateral, it goes to the side that is pointed toward the x-ray tube. These are gonadal shieldings that we might use to shield gonads. We don't use these very much anymore because it's hard to know exactly where the gonads are, so these are becoming less and less used. A lead curtain. This is in the fluoroscopy unit. This is a lead curtain because we would get scatter coming from the radiation here when it hits the patient. So this protects the personnel, the doctor, as they're fluoroing. So it's called a lead curtain. We didn't always have these. I remember when we started using these, and that's to protect the person who's doing the fluoro. And there's a Bucky slot cover. It's right along here. This is the Bucky. That Bucky can move up and down here. When you move the Bucky down, this is the x-ray tube when you're doing fluoroscopy. When you move the Bucky down out of the way, this goes out here and it's lead lined, and it as you move the Bucky here, it comes into place and blocks the x-rays coming from the underside of the table. And again, those weren't always used either. Mobile lead shields that you can move around instead of putting it on the patient. And this is a lead barrier that we would stand behind. If you don't have a booth that you can stand in, this is a leaded glass and a lead shield that you can stand behind if you have to be in the room with the patient. You see these in the trauma center a good bit. Radiation safety, if we're talking about that, if you practice radiation safety, x-rays are not, our x-ray profession is a not harmful to you. If you practice radiation safety properly, we will discuss basic principles in just here as ago. We go by the rule of ALARA, and every X-ray tech should know this. It stands for as low as reasonably achievable. I can't tell you exactly how much radiation you need to use on any given situation or patient, but we always want to use as low radiation as achievable to get a quality image. So it is the philosophy that all reasonable actions will be taken to reduce dose to patient and personnel. Um, we practice the concept of linear non-threshold. In other words, linear, it goes in a straight line, and that straight line can be angled more this way or more this way, but it's linear, it's not up and down. But it's non-threshold. We don't know at what point you will start getting cancer or long-term effects. We do know that the greater the dose, the more likely you are to have an effect from it. So simply put, linear non-threshold means we practice as if any amount of radiation can show a response to us or cause damage to us. Note, the graph, it starts at the beginning, and meaning any dose will show a response. The greater the dose, the more response you will have. Cardinal rules of radiation. This is the other thing besides the LARA that I'm going to ask you to know. Time, distance, and shielding. Limit your time under the exposure, or limit the patient's time also. If you're doing the x-rays or you're in the fluoro room, increase your distance. There's something called the inverse square law. If I double my distance, I reduce the exposure down to one fourth. If I half my distance, my exposure goes up 4 times. You will talk about that next semester. And using shields, whether you're standing behind a lead shield, whether you're using a thyroid shield, whether you're using a lead apron, you're shielding yourself from the scattered radiation. There's two sources for medical for X-ray. Two sources for medical imaging of radiation. There's X-rays, there's which we use that are produced from an X-ray tube. There are also gamma rays that are emitted from the nucleus of a radioactive atom. So this is the nucleus breaking down, putting out different radiations, alpha, gamma, and beta radiation. The gamma radiation is what we use to make our images in nuclear medicine. So gamma rays come from the nucleus of an atom, X-rays come from an X-ray tube that are produced. We will. I'll just say a little more about this. Radionuclides are how we use these gamma rays. We take uh, these radioactive source and we this radioactive source, these atoms, and we inject them into a patient. And we tag them to different radiopharmaceuticals. So in X-ray, when you're taking images, we generally stand behind a leaded wall where the control panel is. Um, our wall, the in the X-ray our department, that glass is leaded glass, and the walls have a lead lining, so we're protected. If you'll notice, there's a radiation badge taped to each wall or each door to show that we're not getting leakage radiation out of the room. Radiation comes from the X-ray tube itself, but also can come from patients in the form of scattered radiation. Keep in mind, X-rays are like light. When you have the X-ray machine on, it's producing X-rays. When you have the light on, it's producing light. If you don't have the X-ray machine on, it is not producing radiation. Just like when you don't have the light on, it's not producing lights. So I just said radionuclides a second ago. Radionuclides are found in the nuclear medicine department or area. These radionuclides are tagged and then injected into the body part as a radiopharmaceutical. So the radionuclide is what is emitting the X-ray. You tag it or attach it to some pharmaceutical to make it go to the blood, the brain, the bone, or wherever you want it to go. The pharmaceutical decides that whatever you're hooking it to, you can do a lung scan or a bone scan. So it's the radiopharmaceutical that you hook it to that takes the radionuclide to that body part. Be mindful of patients in nuclear medicine as they are emitting radiation. A low level, but the radiation is inside of them, and then you use a camera to detect it. Whereas we're emitting the X-rays externally and using a plate to detect the X-rays. So this is just talking about protection for the patient. Estimates indicate that 65% of the population in the United States receives an X-ray examination each year. I think that's probably high, but maybe because I haven't had many X-rays, but that's what the literature in this book said. A significantly lower total population dose could be achieved by Americans if all radiologic technologists would use protection methods. In other words, if all technologists and all radiologists did their job the best that they could and used ALARA as low as reasonably achievable, you would reduce the dose to the patient by doing fewer X-rays, by not having to repeat X-rays, by doing X-rays correctly, by not fluorine longer than they need, or in actually not ordering exams that a patient does not need. Protection of the patient from unnecessary radiation should be our goal as technologists. This should be an overriding thing that you are the patient protector. Um, How do we protect our patient? We use the correct exposure factors, meaning the KVP and the mass, using the correct ones for that body part. That we collimate, that we make our beam be only the size that we need to cover that body part. That we do these things correctly and mark things correctly and don't have to repeat the exam. And then that we use shielding for ourselves or shielding for the patient when it is necessary and called for. So using the correct factors, using collimation, reduce our repeat exposures, and by doing proper shielding. Exposure factors, we've already talked about this a little bit. We want to use the proper KVP and the proper MAS, and we'll talk about that more later on. Collimation is just what it says, that there's some internal things in here that little lead shields that open up and let us expose a larger area or a smaller area. Collimation is the restriction of the beam to the uh, to a limited area or the area that we're interested in. We should be collimating whenever possible to reduce patient dose to unnecessary parts and to reduce scatter. Because the more you open this up, the more divergent beam, the more scatter you're going to get. So uh, just collimate to the size or part that you actually want to see. Repeat exposures, if you do everything right to start with, you will reduce your repeat exposures. We are going to ask you to keep a log of your repeat exposures also. Gonadal shielding, like I said, this has become a little bit controversial. At Memorial Hermann, we are no longer using any shielding unless the patient requests it, and then we tell them that it's not recommended now because of studies and We have a pamphlet we can show them, but if they want it, we will still give them. Gonadal shielding on the female is really difficult because the ovaries are not at the same place. I mean, they're variable. The testes also are somewhat variable, but more in the same place. But if you're doing anything on the abdomen or the pelvis, then you're more likely to get the shield in the body part that you want and have to repeat the exposure. So we're still teaching it, but that's a little bit controversial. Personnel protection. The radiologic technologists who receive chronic low doses of radiation are more likely to be affected by the harmful effects uh, uh, of the radiation. The factors and methods discussed for minimizing patient exposure are equally effective for reducing personnel exposure. So if we stay a little time in the room where an X-ray is being done, if we keep our distance, and if we use shielding, we're protecting ourselves. But uh, one of the basic things is distance. If you just double your distance, no matter how much you double, if you go from 1 inch to 2 inch, you've already cut your exposure down to 1/4 of what it was at that distance. So the more you can move away, the better you are. Personnel protection methods. During fluoroscopy, stand back from the x ray table several feet, unless you must attend to the patient or assist the radiologist, and then spend as short a time doing that as possible. When performing portable radiography, use the exposure cord all the way out to its distance. In other words, we recommend, if you will notice on the portable machines, the exposure cord is 6 feet. You should use the entire 6 feet and be at least 6 feet away from the patient, and you should never be in the primary beam. And that primary beam is that radiation that's leaving the patient, leaving the tube. In general, this is a good concept for all individuals. Stand 6 feet or 2 meters away from the source of radiation exposure. If you will be in the room for fluoroscopy or surgery, you must wear a lead apron. The safest place for operators to stand during a radiographic exposure is in the shielded booth or in the back behind the lead glass or the lead panel. Radiologic technologists should not hold patients or image receptors for an exposure. That is ideal, but that is not what's going to happen most of the time. Especially in emergency situations and patients that are really critical, you may have to, not as a student, students cannot, but as a technologist, you are going to have to hold the image exposure. But you're never going to stand in the primary beam. You should be as far away from that image receptor as possible when you can still do your job, and you should have on a lead apron, and you should have on your radiation monitor. At no time must anyone assisting be struck by the primary beam, including the radiographer. And this is just a thing showing scattered radiation. This is the radiographer is standing behind this lead wall, the leaded glass. You can see this is the primary beam coming out. It hits the patient, and then you get scattered radiation going everywhere. Scattered radiation, if we were in the room, would be harmful to us. It also degrades the image on the image receptor. Personal monitoring devices, all of you have what we call a film badge, but actually it's not a film badge in there. It's a personal monitoring device. You should always wear a dosimeter to track your radiation exposure. Again, this does not protect you. It merely lets you know how much exposure you've had over a period of time. Generally, the dosimeter is removed and changed monthly or quarterly. We do it on a quarterly basis here. Proper use of the dosimeter, you should wear it. If you're not wearing a lead apron, you should wear it all the time. It should be up at your collar area or your upper chest area. If you're wearing a lead apron, it should be worn outside the lead apron to show the maximum exposure that you would be getting if you didn't have an apron on. So when wearing a lead shield, you will wear it outside the lead shield at the collar level. That's going to be a question on the test. Proper use of fetal dosimeter. If you are pregnant and you have declared pregnancy to us, we will order what's called a fetal or a baby dosimeter or a fetal dosimeter, and usually they have a little image of maybe a baby on there. You will still wear your regular dosimeter outside of the badge because this is telling the radiation you're getting. You will wear the fetal dosimeter at abdominal level or about the waistline, and it will be worn, if you're wearing a lead apron, it will be worn under the lead shield of the abdominal area. So your personal one for you outside the lead shield, if it's a baby or a fetal monitor, it will be under the lead shield. This is an example of how it should be worn here. A dosimeter measures the radiation you receive. Again, I've said this does not protect you from radiation. It is merely a tracking device to show how much radiation you have received. You're not to hold patients during X-ray exposures. In general X-ray, you will not hold patients or imaging detectors as a student. As a real technologist, you will have to do that. You can stay in the room as a student when you're assisting with a fluoroscopic patient. It requires the personnel to be in the room during this exposure, which is different from just doing a general X-ray exposure. Fluoroscopy, you can be in the room. Again, you should not be the one holding the patient, but you can assist in other ways. I'm not really going to go over this right here. This is just talk about the dosimeter policy. I meant to remove this